All right, I have a 81-year-old Caucasian female with a chief complaint of altered mental status and loss of coordination in her hands. She's not sure when this all started, but it occurs several times daily. It doesn't correlate with any particular time of day or season, and nothing makes it better or worse. When it comes to severity, the patient just thinks that it's because she's getting older, but her husband is actually really concerned. He says that she's having trouble finding words, that she's having trouble buttoning her clothes and putting on her pajamas, and she's been dropping more objects recently and just is more forgetful and absent-minded. He said that she doesn't even remember what she had for breakfast this morning, so he was really concerned. She's never experienced anything like this before. She denies any recent travel or recent illness. She has no history of stroke or blood clots or bleeding. But she does say that she had a fall several months ago, but she didn't have any injuries, so she didn't seek any medical care for that. She is allergic to penicillin. DXR didn't state their reaction to it, but she doesn't have any environmental or food allergies. Her past surgical history was also not listed in DXR. She has a past medical history of hypertension, anxiety, and insomnia, for which she takes 50 milligrams of trazodone, 30 milligrams of nifedipine, and 0.5 milligrams of lorazepam as needed. She doesn't take any herbals or any other supplements or over-the-counter medicines, just Tylenol occasionally. So DXR doesn't state any of the ages of the family members at their time of passing, but her father died of natural causes. Her mother died of diabetes. She has a brother that died from colon cancer and a sister that died from stroke. She has a living brother who has heart disease and a younger sister who also is alive with hypertension. She denies any alcohol, tobacco, or illicit drug use. She does walk occasionally for exercise and denies any major life stressors or any major changes. She does not drink any water. She only reports having 4 to 5 cups of caffeinated coffee a day and is on a high-protein diet. For immunizations, all DXR said is that she had the tetanus and smallpox vaccine, but didn't state any of the other ones. On review system, she denies any fever, chills, fatigue. She does report a 3-pound unintentional weight loss. She denies any skin changes or a rash, any heat or cold intolerance. She denies any headaches or dizziness, and that is whether she's at rest or with position changes. She denies any changes in her vision. She has no problems with any eyelid droop, but does wear glasses for reading. She denies any other HEENT symptoms and has no difficulty swallowing. She denies any neck swelling or tenderness to her neck. She denies any chest pain or palpitations, denies any shortness of breath, dyspnea, or wheezing. She doesn't experience any nausea or vomiting, constipation, or diarrhea. She has no urinary changes. She denies any musculoskeletal weakness, although she does say that sometimes both of her hands feel just a little bit weaker than they used to. She denies any lower extremity swelling. She does state that she loses balance occasionally and has to use something to steady herself. She does have difficulty finding words and is just a little bit more clumsy. She has trouble picking things up and drops things often, and does have a little bit of a tremor in her hands. But she denies any recent fall other than the one a couple months ago. She hasn't had any seizures or syncope. She denies any numbness or tingling or behavioral changes or any mood swings. She also denies any changes in her sensation of touch, taste, or smell, and has no difficulty writing. She does report intermittent anxiety, but does not state that she has any problems with depression. So on exam, she's a healthy appearing 81-year-old female that looks her stated age. She's sitting upright on the exam table with no apparent distress. She's alert and oriented to person, place, and time. She's cooperative and follows commands. Her skin is warm and dry without any lesions or rash. Her face and smile are symmetric, and she's able to raise her eyebrows symmetrically. Her eyes are symmetric, pupils are equal, round, and reactive to light and accommodation. Her extraocular movements are intact with no nystagmus noted. Red reflex is present. No AV nicking, hemorrhage, or exudate noted. Ears, nose, and mouth all have no abnormal findings. Her neck is supple without any lymphadenopathy or tenderness. Her thyroid is palpable and smooth, non-tender without any nodules, and it rises with the trachea with swallowing, and there are no carotid bruits heard. Her breath sounds are clear throughout. She has normal S1 and S2 heard with no murmur and regular rhythm. She has normal active bowel sounds and no tenderness or masses on palpation. For her hands, she has normal pin and cotton whisk sensation to both hands, although she does have trouble with 2-point discrimination. She also was sluggish on the left hand with the finger to nose touching, as well as rapid alternating hand movements. For her memory test, she couldn't remember 3 words after 5 minutes. She was unable to subtract 7 from 100 in a series. Her speech was intact, but she had some trouble with word finding. She was able to read and write okay, but when she was asked to repeat letters and words and sentences, she had some difficulty there. She also had difficulty with graphesthesia. She had no swaying noted on her Romberg. Heel to toe and gait were intact. She was able to hop on one foot just fine. Her reflexes were all intact, and she had normal affect and no deficit in her judgment. Her blood pressure was 158/70. Her heart rate was 60. Her respirations were 16, and she was 97% on room air. She is 5'3" and 130 pounds. So my first differential was stroke. I also thought about electrolyte imbalances and dehydration, since she doesn't drink any water, because potassium, mag, sodium, and calcium alterations can cause muscle tremors and some confusion. Parkinson's also has, tremors, loss of balance, speech changes, some confusion, and can result in falls. And then in the elderly, a UTI could also cause some confusion, but it wouldn't really explain her hand issues. So I went ahead and ordered a bunch of labs, which were all normal: metabolic panel, CBC, PTINR. The UA was normal. I ordered a vitamin B12 because a deficiency there can cause some poor balance as well as memory loss, but that was normal. Hyperthyroidism can cause some tremors, so I tested that, but that was normal as well. And then I was thinking of why did she fall? And with her hypertensive history, I went ahead and did orthostatics on her, and there were no changes there. EKG was normal sinus rhythm, and then I got a lipid panel as well, and that was normal. And then the head CT showed a large left subdural hematoma with compression of left cerebral hemisphere with a right shift of midline structures, chronic in nature, with no evidence of infarct. So final diagnosis is stroke, presumably due from her fall a while back, since it was chronic in nature on the CT. So in DXR, I actually went ahead and sent her to the ED and then had all those tests ordered, the labs and the CT and all that while she was there. I made her NPO in case they wanted to do surgery, and I consulted the neurovascular surgeons. But I was curious as if that was the right thing to do or not. So to my pearls, I looked up in DXR, up to date. And so there were different things, obviously, for acute and chronic subdural hematomas. Obviously, the acute ones, your time is brain, you're going to send them straight to the ED and do the whole workup. And but for ones that were chronic in nature, whether or not they were a surgical candidate is kind of what drove your practice. So there were several things that made them a surgical candidate. So one was that there had to be a midline shift greater than 5 millimeters. And DXR didn't state how big the shift was, just said that there was one. Also, an increase in intracranial pressure could make someone a candidate for surgery. So I could have done an LP to see if there was any change there. And then it also depended on patient's symptoms, if they were having any, deterioration over time, which I think this patient was having. And if you treated her on an outpatient basis, you would refer to the neurovascular people and make sure you tell her not to take any aspirin or Alka-Seltzer or BC powder or any type of blood thinning medications in the meantime. But I think if I were to do it all over again in real life, I would have just sent her to the ED anyway. With them not being sure of when the onset of symptoms was, what if it was like a new stroke? And she could have gotten the CT and all the lab work and everything would have been done much faster in the ER. So from a primary care standpoint, I think that if this happened to me, I would just go ahead and send her to the ER for presumed stroke. And then I would want to follow up with her within 1 week after hospital discharge. Some other pearls, I didn't note any tongue deviation or blurred vision. And there was no way for me to test the like arm drifting test. So, you know, the FAST acronym for stroke. So F, we did the facial symmetry changes, facial droop, and there was no issue there. The arm drift, we didn't test that. Speech was intact, but she did have some word finding difficulties, so it wasn't quite slurred speech for the FAST acronym. And then time is brain. So again, just to be safe, go ahead and send her to the ED. Some of you ED nurses can maybe touch on that a little bit more, but I think in this, I wouldn't have been able to get a CT fast enough to know for sure. So I think the right thing would have been just to go ahead and send her to the ER and have this all played out there. Thanks, guys.